In all parts of the health system, ever since we really had a health system, we've talked about how to improve things. We've talked about change. In earlier incarnations of that, we talked about people managing change and being change agents, trying to improve policy or practice or clinical care or the way we run organisations. We've changed the discussion recently in the last couple of years, and we've introduced this very interesting phrase called implementation science. Could be that that's just old wine in new bottles, or it could be that this is a paradigm shift in thinking about how do we give better care to patients, how do we improve it on a continuous basis. And that's what I want to talk about in this short session. I'm Geoffrey Braithwaite, Professor of Health Systems Research at Macquarie University, and I want to talk about this idea of implementation science. One of the things we know is that things won't improve just through osmosis. They won't just change because we issue a new policy or a new drug is designed and tested or a new piece of equipment comes into play. It won't just happen accidentally or because people will just suddenly see the light and take up this new way of doing things or this new technology. It also means that we won't be able to just issue a new thing right across an entire health system and expect every setting to take it up ubiquitously in the same way, in the same pace, at the same time and get the same results. Because context always matters in healthcare. One public health unit or community health setting is different from another. It's different culturally, it's different resources, it's different people, it's different services that they provide. So what implementation science does is say several things to us. One is to work on and with local context. That means work on the local characteristics of the complex adaptive system that we're trying to improve or change. Another one is to think about what are the barriers and facilitators to implementing something new, say, getting more evidence into practice, into clinical practice. Another point is having an implementation plan would not be a bad idea. Just doing it on the hoof, just guessing how this might turn out, isn't enough today. We really need a game plan. Let me give you an example. We've been working with some clinicians looking at how they deliver care to patients with Lynch syndrome. It's a condition that precedes people getting cancer, colon cancer. And so we asked these clinicians, how do you deliver care? What does it look like? And they said, essentially, we get people in, we screen them, and then we refer them. And then we dug deeper and did some ethnographic observational research and worked with people and talked to them. We fleshed out a much more complex picture with many, many steps. It wasn't just get people in, screen them, and refer them. It was much more complex than that. It was the complex adaptive system, the care delivery system in practice. And so we've used ideas from implementation science to work with this clinical group to try and improve the way people come in to care who have Lynch syndrome, get screened, and then get referred and get treated. And we've dealt with this much more about the context within which these clinicians work and also about the way they deliver care in a much more complex way than we previously thought. Implementation science. It's a kind of newish phrase. It's more than just old wine in new bottles. And we'll be talking about that much later as we write a series of articles and books on this topic.